Good morning, everybody. I want to thank again my colleagues from the Manos Dodongiannakis team and Manos Brilakis for again inviting me in this very beautiful course. After so difficult period that all the world passed, and maybe it's not finished yet. It's a pleasure to be here, and I'm honored to be among you. So I want to talk about the cuff pathology from the radiologist's perspective, but I saw from the previous speaker that I have a lot of things to learn more. So, which is our perspective? The question has to be answered by choosing the aim of our job. And our role is to be sensitive enough to depict the changes of the rotator cuff, mostly those that are reversible. So, we try to start from the beginning of the spectrum of the pathology of the rotator cuff, from tendinitis and tendinopathy till the end stage problems that we have with the glenohumeral arthrosis. We will cover all these in more details, and also, if we have the time, we will speak about some conditions that sometimes may be confused, clinically confused, but we can answer them with the imaging and using all the techniques of the imaging. So, we start with tendinopathy. Tendinopathy is the early inflammatory process that has the first stage of peritendinitis or tendinitis with subtle edema around or within the tendon, and not very often at the first stages, focal tendon thickening or on high resolution MR imaging. So, here, does it work? Yeah. Here we have an adolescent, he's an athlete, and we have this edematous interstitial tissue in rotator cuff, and very, very subtle peritendinous edema. We don't have findings of tearing, but the main finding of this athlete, this is accompanying finding of the main finding that we have the stress injury through the growth plate of the humerus. So it is accompanying finding, it's not the primitive finding that we have. Then we go as the process evolves, and we have the second stage that we have the degenerative tendinopathy, that fibroblasts and the inflammatory changes produce an increase in tendon thickness and changes of intrasubstance echogenicity on ultrasound imaging, or changes of the signal intensity on MR imaging. So, sorry. We can see it here. Doesn't work very well, yeah? Yeah. We can see it here as a thickening and edematous process inside the rotator cuff fibers. And here, also we have a thickening, but it's not yet a tear. These are precursors of tear. It depends on the quality of life and the occupational problems, and if somebody is an athletic guy. So we have all these changes evolving. Then we pass to rotator cuff tear. And we have a checklist as radiologists to answer, to give the more details we can in order the surgeon or the clinician will decide how he will go on with his patient. In the partial tear, we find fluid echogenicity in US, or high signal intensity on fluid sensitive imaging sequences, mostly in T2 and less on PD. It's not so serious if you find it on PD sequences, but you must find it on T2 fat saturation images. And then we start to divide the lesions according to the location, and we know all these classification, to articular. The mouse, I think it's a little bit problematic. Articular, intrasubstance, and dorsal. It doesn't move very well. Okay. And then we have to report the thickness of the lesion, and we divide them mostly in two categories. One, that is, the thickness is less than 50%, and the second is if the lesion is above 50%. But also a subdivision to the first group, to those that are less than 3 millimeters and those that are between 3 and 6 millimeters, is very helpful, mostly for the athletic population and the younger population. We have the articular partial tear, the well-known PASTA lesion, that PASTA is the acronym of the partial articular supraspinatus tendon avulsion. And I'm sorry, maybe I'm doing something not very well. Δεν δουλεύει. Ναι, το κάνω, αλλά κοίταξε. And also we have the rim-rent tear. Now it's better. The rim-rent tears, the footprint tears. All these lesions are well seen in T2 fat-saturated imaging. You see them at the level of the articular surface. The intrasubstance partial tear is when we have the lesion inside the fibers that do not communicate with the bursal or the articular surface. Sometimes they can be complicated. And then we pass to bursal partial tear, and we also can see them without arthrographic technique, because most of times it is associated with fluid in the subacromial space. So it can be delineated, but we cannot see them on MR arthrography because these lesions do not communicate with the joint. One interesting type that we refer to this type more often during last years is the delaminating type. The process of tearing where there longitudinal split. We have a vertical component and a second, a longitudinal component that splits the fibers, and it separates the fibers, so we can see this delamination as we know it mostly in articular cartilage lesions. So, I'm sorry, but it doesn't work. We have separated these lesions. We know these lesions only, not only in a partial tearing, but also in complete tearing. So, here, the upper image, you can see almost complete tearing. And the second image, it's a complex partial tear that it's intersubstance, but it can be avulsed. All the tendon can be avulsed and can be retracted. So these lesions also can be retracted. We pass to the full thickness tears that have their own checklist. We answer to the questions. Is it incomplete full thickness tear? That means that it refers to a part of the width of the tendon, not all the width of the tendon, but in all the thickness of the tendon at its width, the width that we refer. We have the complete full thickness tear that refers to all the width of the tendon. We have the complete full thickness tears with retraction, and finally the retraction with atrophy. We also divide them, and we have to categorize them when we are talking about which size has the lesion, which its location, at which stage of the retraction is the lesion, is it accompanied by muscle atrophy, and we can measure it by looking at the quality and also the quantity of the muscle. So with the full thickness tears, we can see the sequential images, and we will see, as here, we have 5 sequential images on coronal plate, and all the planes have the thickness of 3 millimeters, so the width of this lesion is 1.5, so it's a medium lesion. Also, we divide them when looking the location and the extension, and we see from the posterior superior part to the anterior part, and we have the rotator cuff, and we can go through bidimensional measurement, as here in the coronal plane and the sagittal plane. Also, we must stage the retraction, and we divide this in 3 grades. The first one, when the retraction is close to the insertion. The second, when the retraction is at the level of the humeral head, in the middle of the humeral head. And the third, when it's at the level of glenohumeral joint. Going to the muscle atrophy, it started by Goutallier in 1993. Then radiologist Zanetti also, it started by CT scanners, using CT imaging. Then it produced with the sagittal imaging progressed in the sagittal T1 imaging on the oblique plane. And now, after Isakos administration, now it's here the well-known now new classification when we start with the muscle, normal muscle, and we finish when we have more than 50% of fatty infiltration. Also, another one, more quantitative measuring is the Tangen sign, and we put a line between the spine. We unite the spine with the coracoid process, and also the coracoid process, the tip of the coracoid process with the lower tip of the spine, and we see which is the percentage of the volume of the muscle is above this line. So we also can grade these lesions from normal to severe. So we have a good details. We can give you good details about the condition of the muscles. At the end, the massive rotator cuff tear refers to the condition when we have more than 2 tendons with full thickness tear, and the retraction is more than 5 centimeters. We have some accompanying findings sometimes, like this geyser sign, as you see below. So it's because of the altered biomechanics of the movement of the fluid, so it migrates upwards, and it can produce these cysts that are produced due to the geyser phenomenon. It's the geyser sign. Sometimes, I've seen a patient that came to me. He had forgotten to use his upper extremity because of severe arthrosis, and he came terrified by this lesion because he thought that it was a tumor. So at the end, we go and we end at the glenohumeral arthritis with the well-known Hamada classification at the end stage with severe changes, deterioration of the joint, migration of the humeral head with necrotic lesions, with cysts, with deterioration, and a very small subacromial space. I will finish now with subscapularis tendon because tears are more frequent than we previously thought, and they are underestimated in all imaging techniques. The sagittal plane is the best for the MRI evaluation, and on MR arthrography, we strongly recommend external forced rotation for better depiction of the partial articular-sided tears. And the best classification that we also use is the Lafosse classification according to which part of the subscapularis tendon is affected, and which is the position if the head, the humeral head is centered, and which is the condition of the muscle if we have fatty degeneration of the muscles more or less than stage 3. These lesions are associated with rotator interval lesions, long head of biceps lesions, and dislocations of biceps, and tearing of biceps, and also sometimes with slap lesions. So we have to look very thoroughly to find the subscapularis tendon pathology. I will finish my presentation here, and if you want, we will talk about the conditions that can mimic the pathology of the rotator cuff. Thank you.